Hi everyone. Today we will try to discuss renal physiology. Um, Before we study the nephron, the different transporters and the different formulas, we need to ask a very one simple question: why does the kidney matter so much? The answer is that the kidney is not just making the urine. Okay, uh, kidney is one of the main organs that keeps your internal environment stable. Every day, our body is constantly changing. We drink water, lose water, eat salt, produce acid, generate waste. Despite that, our plasma composition remains within a narrow range. So that does not happen automatically, but the kidney is continuously adjusting all that. It is maintaining the volume, the osmolarity, the electrolytes, acid-base balance, and the waste excretion. That is the reason that if in case the kidney fails, the whole body becomes unstable because now there is no check on all these things. So renal physiology is not just about urine formation. It is really the physiology of maintaining stability in a changing body. Uh, so, renal physiology becomes easier if you stop thinking of it as a list of transporters and start thinking of it as a mechanism to maintain the homeostasis. The kidney is constantly deciding how much water to keep, how much sodium to keep, what waste to remove, how to protect the pH, how to maintain the pH, and how to adapt to different physiological needs of the body. Urine is just the final result of all these tiny decisions. So, if that is all the kidney is doing, it is maintaining the volume, it is maintaining your electrolytes, it is maintaining your pH, it is excreting the waste that can be harmful if it reaches more than a maximum value. So, instead of memorizing nephron, let's just follow one drop of blood and see what happens to it. So, this is the complex sexual structure of the nephron. So, this is the renal artery. From here comes the efferent artery. There is this tuft of loop inside the glomerulus, and this is the efferent artery. Then that becomes peritubular artery and runs all around nephron. So, and in nephron, the first part is the Bowman's capsule, in which the glomerular tuft lies, followed by the proximal convoluted tubule. Then there is this loop of Henle, which has two parts, the descending loop of Henle and the ascending loop of Henle. Then is the distal convoluted tubule, followed by collecting duct. So if we just simply try to figure out a journey of a drop of blood, let's assume that a drop of blood filters out of that comes out of this efferent arteriole, the branch of the renal artery. So the blood will enter into the glomerulus, and which is like a sieve-like structure. Here, the initial decision is made what to filter and what not to filter. There are certain things that can pass through this glomerular basement membrane and the Bowman's capsule and enter inside the PCT, and some things can't. So once it is inside the PCT, uh, now the filter here the body reabsorbs as much as it can. So PCT is the bulk reabsorption point where almost everything is absorbed. Like if in case your glucose levels are within a normal range, then PCT will absorb all of it. Then there is loop of Henle. Now the loop of Henle is the region where there is this system of counter current. We will study it later, and it is responsible for maintaining a medullary osmotic gradient. Then it will go to DCT. DCT has many receptor and many specialized cells, which we'll see later, and it does fine tuning again, which helps the kidney to maintain our pH and homeostasis, which is at last followed by the collecting duct. Collecting duct is basically the region where there are ADH receptors for antidiuretic uh, hormone. And here the decision of how much water to be saved to maintain the volume of blood or how much water to be excreted is done. So, if you think you can also think of the nephron like a factory. So, glomerulus is the part where the screening happens of what can go inside and what cannot. Then PCT is the bulk recovery department. with and it in here it reabsorbs most of what we need, followed by loop that generates the gradient, followed by the distal convoluted tubule that is the fine tuning agent, and at last the collecting duct where the decision of uh, water absorption is made. Then, so coming to the glomerulus. Now, why does the fluid leave the blood in the glomerulus? Then that is a decision made by the difference in the forces that are pushing the fluid out of the glomerulus into the PCT and opposed by the pulling forces. So basically, this is a efferent arteriole of the glomerulus, and this is the efferent arteriole. So in efferent and in between is where the filtration happens. So there are two pressures that are supporting the filtration. One is the hydrostatic pressure inside the glomerulus, and second is the oncotic pressure inside the tubule. Though usually in normal circumstances there is no protein filtered out, so that is nil. Then the opposing forces are the hydrostatic pressure, the pressure by the fluid itself in the tubule, and the oncotic pressure, the negative pressure by the proteins present inside this glomerular capillary. So to summarize, the uh, filtration in the glomerulus is driven by pressure. The main force pushing out is glomerular hydrostatic pressure, and the force is opposing it is the hydrostatic pressure in the Bowman's capsule and the oncotic pressure of the plasma proteins inside the capillary. Uh, Now, if we go into numbers, the hydrostatic pressure inside the glomerulus is 60, which is the main force responsible for filtration. And this hydrostatic pressure of 18 and this oncotic pressure of 32 are the opposing forces. So the net filtration pressure is this minus these both. That is 60 minus 18 minus 32, that comes out to be 10. And this can also be represented by this term PGC. So you can say that GFR is directly proportional to PGC. And if we have to go to a formula, GFR is equal to the coefficient of every equation as a coefficient. Na? So the coefficient of filtration, then PGC is the hydrostatic pressure in the glomerulus, PB minus PBS and pi GC. Now pi GC is the oncotic pressure inside the glomerular capillary, and PBC is the hydrostatic pressure inside the Bowman's capsule, and this determines the GFR. So now there are other factors also that control the GFR, and that comes down to two things: the efferent and efferent arteriole. The efferent and efferent arteriole acts like a knob, and basically how which knob is opened and which knob is closed will also add on to the GFR formation. So if we see the efferent knob, that is the efferent arteriole. If the efferent arteriole dilates, there is an increase in PGC, that is the hydrostatic pressure inside the glomerulus. And we just saw that it is directly proportional to GFR. So the dilatation of efferent arteriole leads to increase in GFR. However, if the efferent arteriole constricts, there is decrease in renal blood flow, that decreases the PGC, and there is a net decrease in the GFR. Now, if we just simply see how things will change if the efferent knob is changed. So if you constrict the efferent arteriole, there will be a increased flow. There will be obstruction to the flow. So there will be increased hydrostatic pressure here, which will increase GFR. However, if you dilate the efferent arteriole, the fluid will move faster, decreasing the PGC, thus decreasing the GFR. However, it has another complexity to it. If you constrict the efferent arteriole for long enough time, the proteins will also start to accumulate inside the capillary tuft of glomerulus, and they will increase pi GC, and pi GC is the opposing force to formation of GFR. So constriction of efferent arteriole can also lead to decrease in GFR if the pi GC is increased substantially. Now, once there is filtration has happened, the fluid through this through the result of this net filtration pressure and the difference in the push and pull forces have entered inside the PCT, inside the nephron. Uh, what happens to that filtered fluid? Do we lose everything? Uh, so it isn't like that, obviously. Unlike us humans, kidney is very smart and it knows what to take back and what the body needs and what to excrete. So these are the of a PCT. And if you see these are the number of receptors that are present in a PCT cell. This is the brush border that increases the capacity of PCT to absorb. These are the different receptors. This is the lumen of the proximal tubule. This is the PCT cell, the interstitial space, and the peritubular capillaries with blood running into them. So here PCT tries to reabsorb as much as possible of whatever the body needs. The key substances that the PCT absorbs is glucose, amino acids, sodium, and water. And like I told, in normal circumstances, if the glucose inside your body is in a normal range, the PCT will absorb it all. And once the fluid after post PCT, there should not be any glucose normally. So now comes the question that the can the PCT or can the kidney for gross representation absorb everything, no matter how much is filtered through it? So the answer is obviously no, because the reabsorption, as we saw, was carrier mediated. There were different receptors that were responsible for absorption. So this is the mathematical unit for it is transport maximum, and this is the graph. Now on the X for and this will we will see for glucose because it is the simplest. The x-axis is the plasma glucose, and the y-axis is the reabsorbed glucose. If you see till a point, there is a linear relationship. As the plasma glucose increases, there is also increase in the amount of absorbed glucose. But after a point, that is the Tm point, no more glucose can be absorbed as all the receptors saturated. So glucose above this level, all this glucose will be excreted into the urine. This is what it happens in diabetes. That is why there is glycosuria. So again, like I was talking, that there is a maximum point, and if you like for an easy example, you can think of it like a bus. Till there are seats, everyone can sit. But once there is still inflow of people, but there are no seats, people have to stand or like sit on the roof. That is the extra glucose. Now we will see loop of Henle. So again, loop of Henle has two parts. There is this descending part and there is this ascending part. This ascending part is relatively thicker, so it is also called the thick ascending loop of Henle or TAL. Now, in the most simple manner, if you have to remember it, it is that one limb, that is the descending limb, loses water and is impermeable to salts, and the ascending limb pumps salt out of this, and this creates the gradient. If you see the medullary gradient or the interstitial gradient, so here it is 300, but at the bottom it reaches up to 1100. So this diagram is again representing the same, that the descending loop only allows water to exit and the ascending thick ascending part is only permeable to salts, which leads to generation of gradient. The use of this gradient we will see in the incoming slides. So again, remember the role of loop of Henle is not to uh, create urine, but the thing is to create gradient. The descending limb is permeable to water but not to salt, so the water leaves and the fluid becomes more concentrated. And the ascending limb does the opposite. It pumps out salt but does not allow water to leave, so the surrounding tissue becomes salty or the surrounding tissue becomes more concentrated. So if you combine them both together, this creates a gradient in which there is low osmolarity at the top and high osmolarity deep down in the medulla. So just try to remember that the descending limb is water out and the ascending is salt out. So why we need to create this gradient and what is the actual use and who will use it? So that happens at the collecting duct. For for the sake of this initial part of discussion, we have skipped DCT. We will see it in the incoming slides. So in the collecting duct are the receptors for ADH, antidiuretic hormone. And ADH is released through released by sensing the osmolarity. There are osmosensors inside the hypothalamus, and based on the osmolarity, the ADH is released. In case the osmolarity is too high, that means the body needs water to be conserved. The ADH is released, it will act upon the collecting duct, as you can see in the second diagram, and this concentration gradient will help to let this water flow. However, in the absence of these receptors, the water channels are closed and the urine will pass as it is. So this happens when there are enough hydration. The hydration status is maintained and there is no need to conserve urine. So now, like I from the initially we talked that the kidney is not just making urine, but it is maintaining the homeostasis. One important part of that homeostasis is the pH. So in the very basic sense, if you have to remember that the what the kidney does is it takes out the acid from the body, that is H plus ions, and excretes it in the urine and saves or regenerates bicarbonate. So kidney excretes the acid and saves the base. It happens at multiple levels. If you see at this PCT level, there is secretion of H plus inside the PCT, and then at the level of DCT, there is this generation and reabsorption of bicarbonate, and same is happening in the PCT. This how this is happening, we will see in the later slides. So if you have to put all together what all have we discussed till now, the glomerulus is where the filtration happens, the PCT where there is bulk reabsorption, loop of Henle creates the gradient, DCT does the fine tuning, and the collecting duct is the final decision maker. So the outcome of all this is volume control, osmolarity control, electrolyte balance, acid base balance, and waste removal. Thus, doing the function that the kidney has is basically doing through urine is homeostasis. So now we will try to learn a little more in depth. So GFR autoregulation. Basically, the GFR, despite the changes in your physiology and despite the changes in your blood pressure, is very intrinsically maintained by the kidney. And there are two methods how the kidney maintains the GFR despite the constant changes. One is the myogenic mechanism. So basically, what is the myogenic mechanism? That it is a local stretch reflex. The afferent arteriole responds to stretch. In case there is an increase in blood pressure, there will be increased stretch on the afferent arteriole, and that will lead to constriction of the afferent arteriole, thus preventing a sudden increase in GFR. And the reverse happens if there is low blood pressure, then there will be decreased stretch that will cause dilatation and that will maintain the GFR, prevent any fall in it. The second is tubuloglomerular feedback. Basically, the macula densa is the part in the nephron that we will discuss later. These are specialized cells, and these cells can have receptors that can sense the sodium delivery to them. So in case there is increased NaCl delivery, that means the GFR is high, and that will be sensed by the macula densa, and that will lead to constriction of afferent arteriole, decreasing the GFR. And in case they sense that the sodium load is low, that will lead to dilatation of afferent arteriole and will lead to increase in GFR. So this is how, through this myogenic mechanism and this tubuloglomerular feedback, the kidney maintains near constant GFR. So again, like I told, this myogenic mechanism is a local stretch reflex and it is a non-hormonal pathway. So if there is increased perfusion pressure, that is increased BP, there will be increased stretch of the smooth muscles that will lead to constriction of the afferent arteriole, increasing the resistance and decreasing flow. However, if there is opposite of it, that there the perfusion pressure is low, there will be negative feedback and that will lead to dilatation of the afferent arteriole, increasing the flow. This diagram is again showing the same. If there is increased renal blood flow, then the pressure gradient across the vessel increases, leading to a stretch that will lead to constriction, and the opposite will lead to dilatation. Then this is the tubuloglomerular feedback. So basically, the afferent arteriole is in very close relation to this part of nephron that contains the macula densa. So this is a flow chart that is representing the feedback. In case the GFR is high, there will be increased flow through the tubule, and that will lead to increased solute delivery to the macula densa. This will lead to paracrine effect. There will be certain hormones released. Paracrine, there are two kinds of hormonal release. One is three kinds actually. One is autocrine, in which the hormone released acts on the cell itself. Then there is paracrine when the hormone acts on a nearby cell, and then there is endocrine when it affects at a very distant site. So this type of action is a paracrine. So there will be certain uh, chemical release that will act on paracrinally act on the efferent arteriole, leading to constriction, thus decreasing the GFR. So again, you have to think of GFR like it is a water pressure in a pipeline, and it has automatic regulators that sense things when they are on and maintain it within a constant range. The myogenic reflex is a pressure sensor, and a macular densa one is a flow sensor, and this keeps GFR stable. Then apart from it, there is also hormonal control of GFR. So there are at the efferent arteriole, the efferent arteriole requires synthesis of prostaglandins, PGE2 and PGF2, and these prostaglandins lead to dilatation of the efferent arteriole. If something blocks it, that will lead to decrease in prostaglandins and will lead to constriction, thus decreasing GFR. So substances like NSAIDs and COX-2 inhibitors, these things inhibit enzymes that are responsible for synthesis of prostaglandins. So if prostaglandins are blocked, that will lead to constriction of efferent arteriole, decreasing GFR. Apart from it, there are also indirect efferent vasoconstrictors that don't take through directly this pathway. They include substances like cyclosporin and different vasopressors. Vasopressors are the substances that we use to increase BP in case of shock and other disease conditions. Example is like adrenaline or adrenaline. Then on efferent arteriole, there is this substance called angiotensin 2, and it has the receptor AT1R, angiotensin receptor 1. So this leads to constriction of the efferent arteriole, and constriction of the efferent arteriole will lead to increase in GFR. If something blocks this angiotensin 2 action on the AT1R receptor, then that will lead to dilatation of the efferent arteriole, thus decreasing GFR. So the examples are directly there are drugs that are used in hypertension because this angiotensin 2 also acts on blood vessel, leading to constriction and leading to increase in blood pressure. So there are certain medicines we use to decrease BP. However, they have a side effect that they can also block the action of angiotensin 2 on this AT1R and lead to dilatation of efferent arteriole and decreasing GFR. Example is ACE inhibitors and ARBs, angiotensin convertase enzyme inhibitors and angiotensin receptor blockers. Apart from this, there are also direct vasodilators that will directly act on the endothelium cell and lead to dilatation. Example is CCB, calcium channel blockers. These are another class of drugs that are used for treatment of hypertension. Now, if you have to see clinically, now in a patient of like someone came with some pain condition, some musculoskeletal pain or some other thing, and you use NSAID, that can lead to inhibition of formation of prostaglandins at the efferent arteriole, leading to constriction of efferent arteriole and decreasing the GFR. The NSAIDs will hit here. It is shown here. NSAIDs and COX-2 inhibitor reducing the GFR. Similarly, if you use ACE inhibitors, they will dilate the efferent arteriole by preventing the action of angiotensin 2 and will lead to again decrease in GFR. Now there is this condition, disease condition, renal artery stenosis, in which at the entry of the renal artery there is constriction. So there is like due to this condition there is decrease in the blood flow from the efferent arteriole due to decreased space available for the blood to enter. So physiologically, what the body tries to do to maintain GFR is that it causes constriction of the efferent arteriole, so that here the pressure increases and the GFR is maintained. However, in such a patient, if you use ACE inhibitors, that will prevent the angiotensin 2 to act on the AT1R receptor and will hamper the constriction, the safeguard that was happening to maintain the GFR, and that will decrease the GFR. So in case a patient has bilateral renal artery stenosis, that both on the left and right side there is constriction of the renal artery, and in such a patient if you use ACE inhibitors, that will decrease the GFR to like very critical level, and that will lead to increase in the serum creatinine level. That is a endogenous marker of GFR. We will see that later. So that is why it is a contraindication in a patient. If there is bilateral renal artery stenosis, you cannot use ACE inhibitors. Also, normally also if due to this dilatation of efferent artery, there can be a decrease in GFR that can lead to increase in creatinine, even if a patient doesn't have renal artery stenosis. But the safe line is 30%. If a patient has a creatinine of 1 and you give them ACE inhibitors, you have to repeat creatinine after a week. And you can only continue ACE inhibitors if the level is below 1.3. That is 30% increase. If the level of creatinine increase is more than 30%, then you should stop the drugs. Now there is another nuance of this AT1 receptor. Uh, in the previous slides, we discussed that how it is present on the efferent arteriole, but that is not the case. It is both present on the afferent and efferent arteriole. However, the difference is the number and the receptors is different. The number of receptors on the afferent arteriole are far more less than the efferent arteriole. Thus, the action is less on the efferent arteriole as compared to the efferent arteriole. So, what this means physiologically, if there is low or moderate level of angiotensin 2, then that will lead to preferential efferent constriction, increasing the GFR. However, if there is a condition in which there is very high levels of angiotensin 2, now this angiotensin 2 will also act strongly on these receptors that are in less quantity, but as the amount of angiotensin 2 has increased, it will lead to a substantial effect, thus leading to constriction of also the afferent arteriole and can decrease the GFR and decrease the blood flow. So again, this diagram is also showing the same thing, that how if this the width of this arrow represents the density of the receptor and the action. So angiotensin 2 action both afferent and efferent arteriole. However, the action is far more great on the efferent arteriole. Now we will see a bit about the glomerular filtration barrier. This is the thing that is the main, like the main physiological part, how the kidney works and prevents filtration of everything. But it is a control filtration. Only select few substances that need to be filtered goes out through this filtration barrier. So this is a microscopic section of a nephron. This is the efferent arteriole, the glomerulus, the capillary complex, and the Bowman's capsule. So here it has been magnified. So here you see that is the capillary wall. This is the blood inside the capillary. Then the capillary wall is lined by endothelium. But the endothelium here is specialized and has this fenestration, so that the blood can filter out. If there would have been very tight junctions here, that would have prevented any uh, would prevent anything to pass through it. So it is fenestrated endothelium. Then there is basement membrane of this endothelium. Then there are specialized cells on the inner lining of this Bowman's capsule. That is the visceral lining. This is the parietal lining. This is the visceral lining. So the visceral lining has podocytes. Now these podocytes have foot processes, and these foot processes lead to formation of these slit diaphragms, which control the filtration, and not everything would be allowed to pass through. Basically, these are like gates. This is the first gate, then the basement membrane is the second gate, then this foot processes forming this slit diaphragms is the third gate. So like I told, there is fenestrated endothelium which has large pores, but again, it has the pores have a size limit, so it blocks the entry of anything like RBCs. So in case you find RBCs in urine, that signifies there is some damage at the filtration barrier. Then the basement membrane does a very special function. The basement membrane is negatively charged, so it will repel anything that is also negatively charged. For example, albumin. This is the reason why albumin doesn't pass through the filtration barrier, because of the repel. Then there is podocytes. Podocyte is has still fine pores and it is a fine filtration slit. So basically, filtration of anything through the glomerulus depends on three things: the size. If some molecule is very large, it won't be allowed to pass. Then the charge, negative proteins are repelled, and then again, if this barrier is damaged, you will see both cells like RBCs and protein in the urine. Like I told you that it is like a three-layered security system. First is the fenestrated endothelium blocking large objects. Then there is second gate that repels negative charge. Then third gate fine tunes it. So if we have to see with it, this with some clinical conditions. In nephrotic syndrome, there is damage both at the podocyte foot process, and that is called effacement of the foot process, and also loss of negative charge at the basement membrane. So it will present as albumin leak and proteinuria in the urine. Then minimal change disease is a specific type of disease, like I was telling you, which has podocyte injury. It was not nephrotic syndrome is a broad condition. It has many disease. One of them is minimal change disease. The main pathology in the minimal change disease is that podocyte injury, the effacement I was talking about, and this will lead to selective proteinuria. Why selective? Because the charge barrier will still block it. Then there is glomerulonephritis. Anything itis means inflammation, so it is inflammation at the site of glomerulus, and that will lead to structural damage to the filtration barrier, leading to loss of RBCs and protein in the urine. Now we will see a bit about the PCT transport mechanism. In the previous slides, I showed you image that had so many uh, channels in the PCT cell. We will see a few of them. So this is the apical site, the site where the blood is filtered and the urine is being formed, and this is the basolateral site, the site where the peritubular capillaries run and there is blood. So we will start from the apical, that is the luminal event. There is entry of the Na plus inside the cell through Na plus H plus exchanger. It is also known as NHE. So the Na plus from the luminal side, the tubular fluid will enter the cell and will be, because the positive thing is entering and the some positive thing should leave to maintain the charge without any use of energy. So that is why compensatory there is secretion. This is called secretion. If something is being made to enter inside the tubular fluid, that is called secretion, and something is removed from the tubular fluid, that is called reabsorption. So Na plus will be reabsorbed and H plus will be secreted. Apart from this, there is also this H plus ATPase, in which there is single-handedly H plus is being secreted into the lumen, and because there is the charge, there is nothing that is being reabsorbed for this exchange of positive ions, so it requires energy. Now in the lumen there is this special thing happening. This H plus combines with the bicarbonate present in the tubular fluid, forms H2CO3. This H2CO3 is acted upon by a luminal enzyme carbonic anhydrase. This is both present inside the lumen and also inside the cell. So the luminal one will convert this H2CO3 into H2 water and carbon dioxide. Now this carbon dioxide, being a gas, freely diffuses inside the cell, where it again combines with H2O with the help of enzyme carbonic anhydrase, but the cellular one, and that will this H2CO3 is then converted into bicarbonate. Now what happens to this bicarbonate we will see in the next slide. Apart from this, there are also other apical channels that are not represented in this image. One is SGLT. SGLT is a sodium plus glucose co-transport. Basically, sodium helps the transport of glucose. It is also present on the luminal side, and then there is sodium plus amino acid transport, where sodium helps the absorption of any amino acid that has been filtered inside the tubular fluid. This is again the CO2 that is formed diffused inside the cell, and then it is acted upon by the Ca, the carbonic anhydrase in the cellular one, and is converted into H2CO3, which is broken down into H plus, which is again used for the luminal events, and bicarbonate. What happens to the bicarbonate we will see in the incoming slide. So again, this is this formation of H plus that is being again reused through the H plus ATPase and Na plus H plus exchanger for again reabsorption of any bicarbonate that is filtered. This is recyclation. You see the same ion goes inside the tubule, binds with H2, HCO3, forms H2CO3, then it comes inside, then again combines with H2, then the H plus is again excreted inside the tubular fluid, that is secreted, not excreted, sorry. Excretion will happen once the urine passes out. Till now it is just secretion, because there are other mechanisms later that can absorb this H plus again. So this all means that H plus is recycled and not lost. The same H plus ion is used again and again and again. Now we will see the PCT transport mechanism at the basolateral side. So basically this HCO3, the bicarbonate that is formed, it is absorbed into the blood through two channels. One is Na plus bicarbonate co-transporter, and one is chloride bicarbonate exchange. Now these two are also not energy dependent, as a positive and a negative ion are leaving, so it is also charge balanced, and here a negative ion is exchanging with another negative ion. Then also there is this another energy based activity happening, that is Na plus K plus ATPase. in which 2 K plus are exchanged for 3 plus Na plus. So there is a disparity of one positive ion. That is why it requires energy. And this is very essential because this maintains the sodium gradient inside the cell at a low level, so that sodium can enter inside the cell through the tubular fluid. And as we saw that the amino acid, the waters, and most of the rest of the things also come with the help of sodium coming inside the cell through different channels and receptors. So the net effect of all this is that the filtered bicarbonate is reabsorbed indirectly. No net H plus is lost because it is again regenerated, secreted, again reabsorbed, and Na plus and bicarbonate are reabsorbed together. And this, as I said, that there is no charge disparity, so it maintains the pH. So the final message of all this is that you are not directly reabsorbing bicarbonate, but instead you use this enzyme carbonic anhydrase both at the luminal and the cellular level, and it converts it into CO2, which helps it easier for it to diffuse inside the cell, where it is again converted into bicarbonate to get inside the blood. And that how it is the sodium movement is the primary event and everything else is following it, and it helps in the secondary active transport like the S-glut. That is a thing. Why secondary active? Because the primary thing it required was the low levels of sodium inside the cell, which was done by the Na plus K plus ATPase, that was requiring energy. So even if some co-transporter or any other channel is not using energy but is using sodium, that is indirectly using energy. And sodium, the entry of sodium also helps water to get inside and water to get reabsorbed because of osmosis. Now, there is a subtle difference in this bicarbonate and H plus handling at the distal nephron. Distal nephron is basically two types of cell, principal cells and intercalated cells, that is P and I cells. So for now, forget about the principal cells. Now, intercalated cells are again of two types, alpha and beta. For now, we will discuss about the alpha cells. So, alpha intercalated cells are responsible for this H plus handling. So unlike PCT, in which it was bicarbonate dependent, sodium dependent, there was so much other channels involved in all this process. There was involvement of carbonic anhydrase. Alpha intercalated cell directly cause H plus secretion via H plus ATPase and H plus K plus ATPase. So there is no recycling or no dependence on carbonic anhydrase. So basically, unlike PCT, where the H plus was being just recycled again and again, here the H plus ion, that is the acid ion, is actually excreted. And once inside the lumen, it combines with the buffers like phosphate buffer and ammonia buffer so that the pH of the urine is maintained. And also this prevents any further reabsorption of H plus. So again, like I told you that the DCT has two cells, principal cells and intercalated cells. Intercalated cells are again of two type, alpha and beta. So alpha cells are the responsible for excreting H plus and reabsorption of bicarbonate. If you see this alpha cell at the apical site, it has H plus secretion, which happens through two channels. One is H plus ATPase, the another is H plus K plus ATPase. And inside the cell, there is diffusion of CO2 that combines with H2O, which is converted to H2CO3, and there is no luminal carbonic anhydrase, but there is cellular carbonic anhydrase, which will convert this H2CO3 into bicarbonate, and that bicarbonate will then, at the basolateral side, absorbed into the blood. Now this is the beta intercalated cells. So basically beta cell has the reversed polarity of a alpha cell. So what it does is it secretes bicarbonates into the lumen, into the tubular fluid, and it retains H plus. So at the luminal side there is bicarbonate chloride exchanger, and at the basolateral side there is H plus ATPase. So if you have to, like, a easy way to learn is if you see the first two words of alpha cell Al, so it causes acid loss, and Be at the beta causes excretion of base. So alpha cells makes urine acidic, beta cells makes urine alkaline. Alpha cells cause the blood to gain bicarbonate, that is, it will help to correct any acidosis. Beta cells make the blood to lose bicarbonate, so it will correct any alkalosis. Alpha cells are active in metabolic acidosis, and beta cells are active in sorry, alpha cells are active in metabolic acidosis, beta cells are active in metabolic alkalosis. So if you have to see the key differences in the proximal tubule and distal nephron handling of bicarbonate and H plus, proximal tubule reclaims any filtered bicarbonate. because the H plus is also being recycled. So the net effect is zero. However, distal nephron generates new bicarbonate and the H plus is actually excreted. How proximal tubule does this is by CO2 diffusion and carbonic anhydrase. Distal nephron does it with direct pumps and channels and receptors. So also there is this drug acetazolamide that acts on proximal tubule and hinders all this. We will see that in the later slide. The proximal tubule has limited effect on the urine pH control. However, distal nephron through alpha cells and beta cells is the major regulator of your urinary pH. So, some clinical insights, there is this SGLT2 channel, like I said you, that is the secondary active sodium glucose co-transporter. There are certain drugs that are used in patients with diabetes, that is dapagliflozin, empagliflozin. They block this receptor and thus prevents reabsorption of glucose, and the glucose is excreted into the urine, thus decreasing the blood glucose level. Then if all these channels and receptors that are present and the pumps that are present on the PCT, there is this Fanconi syndrome in which all of these are disrupted. There is this Fanconi disease and there is Fanconi syndrome. Both are different. Fanconi disease is a kind of aplastic anemia of the affecting the bone marrow. However, Fanconi syndrome has multiple involvement. One of the thing in it is PCT dysfunction. So there will be loss of glucose, amino acids, bicarbonate. Apart from this, in case the acid handling, if at the proximal site is defective, that leads to type 2 renal tubular acidosis. And however, if it is affected at the distal level, that leads to type 1 renal tubular acidosis. That is, it is also in short called RTA. So, like in the previous slides, I told you that how acetazolamide acts on the PCT, proximal convoluted tubule part of acid and base handling. So, what it does is that it inhibits carbonic anhydrase, both the luminal one and the intracellular one. So basically what was happening that the H plus that was being excreted used to combine with bicarbonate in the tubular fluid, leading to formation of H2CO3, which used to convert to CO2, and that was used to diffuse in and used to for recycling for bicarbonate. However, if acetazolamide is used, it will hinder this conversion of H2CO3 into CO2, leading to decreased diffusion of CO2 inside the cell, decreasing intracellular bicarbonate generation. So the net effect of it will be that and basically this all was also leading to H plus secretion because H plus was recycled na, for formation of H2CO3. So the net effect will be that it will decrease the H plus secretion by decreasing the Na plus H plus exchange because there are no more H plus being generated. This will also decrease sodium reabsorption and decrease bicarbonate reabsorption, and the bicarbonate will remain in lumen and will be lost in the urine. So clinical consequences of all this that the urine will become more alkaline, your blood will become more acid, known as metabolic acidosis with a normal anion gap. This thing we will learn later on. And because of this decreased sodium reabsorption, this will also lead to mild diuresis, that is increased urine. However, it is self-limited and later on different physiological mechanism adapt to it and prevent it. Different uses of acetazolamide, it is used in glaucoma because there it decreases the formation of aqueous humor. It is used in idiopathic intracranial hypertension, it decreases CSF formation, and it is used in altitude sickness because it leads to metabolic acidosis, and metabolic acidosis is an independent stimulant of respiration. So for altitude sickness, it is used to stimulate the breathing. Now, in the previous slide, I showed you the concept of Tmax. It was a bit too theoretical and too simple. Actually, the graph is not like this straight, like there is no critical cutoff level at which the glucose will start to come in the urine. Rather, it is gradual. This curve that forms in this graph is called as splay. So let's study about this concept of splay. So basically, we saw that the initially the filtered glucose increases linearly with the plasma glucose. So as the glucose level increases, the amount of glucose level in the proximal tubule increase and the amount of glucose being absorbed also increase. Now this reabsorption initially matches the filtered load. है ना? At low or normal glucose level, all filtered glucose is reabsorbed. However, there is this Tm, theoretical Tm, that if the blood glucose level reaches to 375 of RBS, the like the load of the kidney reaches of glucose to 375 milligram per minute. Then at that point, the no more glucose cannot, no more glucose could be absorbed and it will start coming in the urine. However, in practical life and in real, we see that this T max is not at 375 but far lower than it, and it is not also this like strict straight, but it is very gradual and it is different. And why this is happening is because the receptors are uh, saturated. There are no more pumps left to absorb glucose. So actual threshold is far lower than the theoretical threshold. This difference is called as splay. The splay is the gap between the ideal curve and the actual curve. And why is this happening? Because not all nephrons have same amount of pumps inside them. So some nephron might start not some nephron might fail to absorb glucose at 180, some might fail at 320, some might fail at 350. So the average number comes out far lower than the T max, that is around 200. So this leads to gradual not abrupt appearance of glucose in urine. So basically splay is the gap in the theoretical value at which glucose should start coming in the urine and the actual value at which glucose starts come in the urine, and it is basically because of the difference in the number of pumps and receptors and channels in different nephrons. So that is why once in diabetes, once the RBF reaches more than 180, more than 200, glucose starts to come in the urine. Also, what happens in pregnancy, normally there is no glycosuria. However, in pregnancy there is physiological glycosuria, and that is normal. It is normal for a pregnant woman to have glucose in her urine, and that does not signify diabetes because there is decrease in the renal threshold. So, at the same level of glucose, a non-pregnant female won't have any glucose in her urine, while a pregnant female can have. Now we will see a more in depth about the counter current mechanism. So basically counter current mechanism has two parts. First is the multiplier and second is the exchanger. The multiplier is basically the loop gradient and exchanger is the vasa recta, the peritubular capillaries running around the loop of Henle. So multiplier, the loop creates the gradient and vasa recta prevents any washout. So again, like I told, vasa recta has the function of exchanger. It prevents any washout of the gradient. Loop actually forms the gradient. Now, why it is called a multiplier? Because we saw that the descending limb is impermeable to salt, so water leaves out of the descending limb. However, if the thick ascending limb, only the salt is pushed out, and they are going in a opposite direction with opposite functions. So it ascending limb multiplies the gradient created by descending limb by running in a opposite direction by being opposite in the water and salt connection to it. So a small difference is far multiplied. Whatever small difference the individual descending limb or the ascending limb would have created is multiplied because of the action of both of them. That is why it is called a counter current multiplier. Now the exchanger, the multiplier part we also saw in the previous slides. Basically, if you see, this is the medulla. Okay, this is the peritubular capillary running around the loop of Henle, and this is the medulla, and the medulla is hyperosmotic. And the blood flow also, like this vessel could have just went straight down, na, rather than forming a loop. So forming of the loop does two functions. One, it decreases the speed of blood flowing through it, allowing things to exchange. And the second thing is basically passive exchange. Now the second thing that is happening is when the descending limb of vasa recta, when the blood is going down, the surroundings are very concentrated. You see, it starts with the osmolarity of 300 and at the bottom it is 1200. So due to this high concentration, what happens is that the water leaves the blood because of increased concentration of water here and decreased concentration of water here, and the solute, the NaCl, enters inside to maintain isosmolarity. And because this is how it happens, stuff goes from high gradient to low gradient. But when it enters into the ascending limb of the vasa recta, the reverse starts to happen. As the blood is going up, the osmolarity is decreasing. So now the reverse of this will happen. Water will start coming in and blood vessels will start to lose sodium. So this gain of salt in the descending limb and loss of water is being balanced by gain of water of the ascending limb and loss of salt. So this preserves the medullary osmolarity that is being created by the loop. Had the blood flow been too fast, it would have prevented this exchange, and had the capillaries not forming a loop, but if this capillary would have been going straight down, then this part would not have been there, and only this thing would have happened that would have destroyed this gradient and washed away this gradient. That is why it is the exchanger, because there is bilateral exchange happening and the net effect is zero. So again, the ascending limb, where the surroundings become progressively less concentrated, solute leaves and uh, the blood back into the medulla and water enters the blood. So again, blood becomes diluted. So the concentration remains same. However, if it would have went directly, it would have become from 300 to 1200, and if, as it would have left, it would have left with all the solutes at a osmolarity of 1200. So again, why all this works is that, again, like I told you, if blood just flowed straight through, it would have washed away all the solutes, the medullary gradient would disappear. But instead, by going down and then going up and going in a slow fashion, there is no net loss of solutes from medulla. Now we'll see a bit about the collecting duct, like how actually there is absorption of water through the collecting duct. So basically, this flow chart is explaining all of it. This is a endocrine part also in it. So basically, in the hypothalamus, there are osmoreceptors. Okay, these osmoreceptors sense this serum osmolarity. Let's say due to some condition, there is increase in the blood osmolarity. That will be sensed by the osmoreceptors in the hypothalamus. This hypothalamus will signal the pituitary to release ADH, antidiuretic hormone, and also will cause increased thirst, that will induce us to drink more water, decreasing the osmolarity and maintain that osmolarity. Now this was the one limb of increased thirst. The second limb of this ADH will go and act on the collecting duct. Here the part is magnified. So basically this is the basolateral side, this is the luminal side, tubular fluid. The ADH will act on a receptor, that is the V2 receptor. It has two receptors, V1 and V2. The ADH will, the receptor that is present on the collecting duct is V2 receptor. So it will act on the V2 receptor. There will be generation of secondary messengers that will lead to exocytosis of a water channel, that is aquaporin 2. This water channel is aquaporin 2. This aquaporin 2 channel will go on the luminal side and will lead to absorption of water. And this water will then enter into the blood. So again, this diagram again is showing the same thing. The from the from first the osmoreceptor sensed increase osmolarity, signal the pituitary to release ADH. This ADH through the peritubular capillaries reach the basolateral side, diffuses out into the interstitium into the peritubular fluid, acts on the V2 receptor. That leads to generation of many secondary messengers, which finally lead to exocytosis of vesicles containing aquaporin 2, that is a water channel that will allow the absorption of water inside the cell, and through this cell this water then again exit into the blood via aquaporin 3. So aquaporin 2, V2, aquaporin 3. Apart from this, there are also aldosterone receptor also. So basically, aldosterone is a hormone that is responsible for maintaining sodium and maintaining blood volume, maintaining pressure, and as a secondary effect of all this, it leads to potassium excretion. So aldosterone, the stimulus of release of aldosterone are two things. First, decrease in blood volume, and second is increased potassium. So what happens is that aldosterone again will come into the blood, diffuse out of the capillary, peritubular capillary, enter inside the interstitial fluid, that is the uh, fluid in interstitial fluid of the collecting duct cells. And here, unlike like ADH acted at a surface receptor, however aldosterone is a lipid soluble, so it will enter inside the cell and as an intracellular receptor. Then there will be many secondary changes inside the cell that will lead to increased expression of one is the potassium channel that will excrete out the potassium, and another is the ENaC channel that will absorb the sodium. This sodium then, with the help of sodium potassium exchanger, will be absorbed into the blood. Water will follow through the water will follow this sodium. So eventually it will lead to increased sodium, increased water inside the blood, increasing the BP, maintaining the blood volume, and will also lead to excretion of sodium in the urine. So this is a simple diagram explaining the aldosterone through its intracellular receptor acted, and there was this generation of many secondary messengers and many secondary signals that led to increased expression of ENaC at the luminal site, which is absorbing the sodium, and increased expression of ROMK that will lead to excretion of potassium. And once this sodium is inside the cell, it will be exchanged through Na plus K plus ATPase and will enter inside the blood. And this all is happening in the principal cells. Like I told you, in the previous slide, there are two cells, intercalated and principal. So aldosterone acts on the principal cells of the collecting tract. So, like I told you that aldosterone has two stimulus. One is decrease in blood volume and decrease in plasma sodium. Basically, decrease in plasma sodium will lead to decrease in blood volume, and second is hyperkalemia. That is increased potassium. So basically, how the decrease in blood volume leads to aldosterone generation? It is through RAS pathway. That is renin angiotensin aldosterone pathway. So the first step is there is dehydration or deficiency of sodium or hemorrhage, decreasing blood volume. This will be lead to decrease in blood pressure. That blood pressure decrease in blood pressure will be sensed by certain special cells present adjacent to glomerulus. That is why they are called juxtaglomerular. Juxta means nearby. These JG cells will lead to generation of renin, a hormone. This renin will act on angiotensinogen. Angiotensinogen is created by liver. So angiotensinogen is present in the blood. However, it requires cleavage and to form converted to into another active form, that is angiotensin 1. So this increased renin will act on this angiotensinogen, will lead to formation of angiotensin 1. This angiotensin 1 goes into the lungs, and here there is an enzyme called ACE, and this ACE will convert angiotensin 1 into angiotensin 2. Now this angiotensin 2 has dual actions. One, it directly leads to vasoconstriction of arterioles. Like we saw how it leads to constriction of efferent arteriole through AT1 receptor. Apart from this, it will go to the adrenal cortex and will act on it and will lead to generation of aldosterone. Aldosterone, the source of aldosterone is adrenal gland. Apart from this, like I told you, that aldosterone is also stimulated by hyperkalemia. So either angiotensin 2 or hyperkalemia will stimulate aldosterone, and this aldosterone will lead to absorption of sodium, increase of blood volume, and excretion of potassium. So in toto, RAS is triggered by decreased BP, decreased renal perfusion, or decreased NaCl at macula densa that stimulates the JG cells, the juxtaglomerular cells, that leads to increased renin and increased angiotensin 2. So the key action of angiotensin 2 is constriction of arteriole. Like we saw earlier that it is present both on afferent and efferent arteriole, however the number is low. And though, and again, the important thing is that it will constrict, not only constrict the efferent arteriole, it will also constrict blood vessels like the renal artery. So, if you see, the GFR will be preserved due to constriction of efferent arteriole, but in total, due to constriction of blood vessels, the renal blood flow will decrease. So, if someone asks you what is the effect of angiotensin 2 on renal blood flow and on GFR, so it is contrary. It reduces the renal blood flow, but it increases the GFR. So certain clinical insights, there is this disease known as SIADH, syndrome of inappropriate ADH secretion. So there will be increased ADH inappropriately to the blood volume status, that will lead to excess water retention, and that will lead to dilutional hyponatremia, low sodium. Then in case there is some defect in the secretion of ADH, that will lead to increased water inside the urine, increasing the urinary output known as diabetes insipidus. There will be polyuria and dilute urine. Now, there are certain conditions in which there is excess secretion of aldosterone. That is non-physiological. Despite the need, the aldosterone is being secreted. That will lead to first increased absorption of sodium, leading to increased blood volume, leading to increased BP. And second thing it will lead to is decrease in the potassium levels because of excretion, leading to hypokalemia. Then ACE inhibitors are the drugs that inhibit the angiotensin converting enzyme that prevents the conversion of angiotensin 1 to angiotensin 2. That will decrease aldosterone because it stimulates the aldosterone, leading to decreased BP by preventing the formation of angiotensin 2 and by preventing the stimulus of aldosterone. Apart from it, as aldosterone is decreased, they also lead to hyperkalemia. So that is a contraindication in a patient who has potassium levels more than 5.5, the normal limit. You cannot use ACE inhibitors. And also, this ACE inhibitors will prevent the constriction of efferent arteriole and can decrease GFR. Up to 30% increase in creatinine, however, is acceptable. In a patient with bilateral artery stenosis, you cannot use them. Then the use of this RAS is basically in conditions of low perfusion, like hypovolemia due to some blood loss, dehydration, or in heart failure. There is activation of this RAS system that maintains the GFR. So now we will study clearance in GFR. So what is clearance? Clearance is the volume of plasma that is completely cleared of a substance per unit time. So, and the formula of clearance is U multiplied by V, which is whole divided by P, where C is clearance, U is the urine concentration of the substance clearance you are calculating of, V is the urine flow rate, and P is plasma concentration. So basically, any substance can have a clearance that is equal to GFR, can be more than GFR, and can be less than GFR. A substance whose clearance is equal to GFR is a substance that is filtered but is neither reabsorbed or nor secreted. The best example of such a substance is insulin. When something can have clearance that is more than GFR, so that thing must be filtered along with that also secreted inside the tubules. Example is PAH, para-amino hippuric acid, and creatinine. And other substances can have clearance less than GFR. Basically, the substance is filtered but is being reabsorbed. The best example is glucose. So the clinical use of this is that we can use creatinine, the clearance of creatinine for GFR estimation. However, this will slightly overestimate the GFR as creatinine is also uh, like PAH also secreted. Then this also helps us to dose the drug because many drugs are excreted through the renal route. So this helps to uh, decide how much dose of a drug to give to prevent any toxicity. Then in disease condition like AKI, acute kidney injury, the GFR decreases, thus decreasing the clearance of a substance. Thus, this substance won't be cleared of the plasma and can be accumulated in toxic doses. Then you can also calculate renal plasma flow through this, and that is used by a pH clearance. So if we have to compare inulin, creatinine, and pH clearance, you have to see that both inulin and PAH are exogenous. However, creatinine is an endogenous marker. All three are freely filtered. Inulin has no reabsorption or no secretion. Creatinine has mild secretion and PAH has extensive secretion. Basically, PAH, whatever amount of PAH that enters the renal circulation is either filtered and whatever is not filtered is secreted. That is the reason that it is used for calculation of renal plasma flow. Creatinine is a approximate marker of GFR, but the advantage is that it is an endogenous marker, so you don't need to give anything extra from outside the body. The only issue is that it can be affected by muscle mass, protein intake, or disease conditions. So, if someone asks you what is the most ideal marker for calculation of GFR, that will be inulin, but that is not day-to-day use, not used in day-to-day life. Rather, creatinine is used. Then it has, as I told, it has certain pitfalls. One thing is that it overestimates GFR as it is also being secreted, and then it is affected by muscle mass, diet, drugs. Again, why inulin is not used? It requires infusion, and the measurement becomes complex. Now, as we discussed, that pH is used to measure renal plasma flow, and as I told you, because almost all of the pH that enters the kidney is removed in a single pass only. So, like if we forget about pH, what kind of substance do we need to calculate pH? We need a substance that gets completely absorbed, removed, sorry, not absorbed, completely removed from plasma in one pass. So that amount entering the kidney is equal to amount excreted, and pH fits it perfectly. But despite that, the extraction is not complete, and there is a little amount of pH that passes off through kidney without being excreted into the urine. So pH gives us a effective renal plasma flow. To calculate the true RPF, you calculate the clearance of pH and divide it by extraction ratio. In case if the pH clearance comes out to be low, either it indicates that the renal plasma flow is less and the renal perfusion is compromised, which is seen in conditions like shock and renal artery stenosis. Now we will discuss something about sodium and volume physiology. Basically, the your ECF volume is determined by sodium because basically you the ECF volume is majorly water, and water follows sodium. So basically, volume status is sodium balance. And then there is this thing, effective arterial blood volume. It is the amount of the volume that is present in the intravascular compartment leading to forming the blood, the total blood volume. and this volume is which is sensed by the baroreceptors. So let's say if there is a true volume depletion, like in conditions of hemorrhage or dehydration, the EABV will decrease. Thus, it will activate the RAS system. The RAS system will cause sodium retention. Water will follow it, and it will increase the ECF volume and the EABV volume. However, in certain conditions, there can be a apparent volume depletion because the effective volume that is inside the blood vessels is low. However, the total volume of fluid inside your body can be high, such as CHF, in which there is low forward flow, cirrhosis, in which there is planchinic vasodilatation, or nephrotic syndrome, in which there is low oncotic pressure. So the total fluid is more than normal, but effective arterial blood volume is decreased. So again, this will be sensed by the baroreceptors and will lead to activation of RAS that will lead to sodium retention. So basically, you need to remember that edema states are states of perceived hypovolemia and not true hypovolemia. Again, this the below point is explaining, but all we have discussed that why does a patient with heart failure who already has excess fluid continue to retain sodium and water? It is because even though the total fluid is high, the cardiac output is low, which decreases EABV, which is sensed by baroreceptor, which activates the RAS, which causes sodium retention, which further leads to edema. So now the regulatory system that are controlling the sodium and volume states, one is RAS, which is activated when there is decreased effective arterial blood volume that will cause sodium retention, increasing the volume. Then there is sympathetic system that will again be activated by the baroreceptors, which will increase sodium reabsorption and decrease the renal blood flow. Then these both are regulated by these peptides, ANP and BNP. ANP is atrial natriuretic peptide and BNP is brain natriuretic peptide. Basically, these substance sense when the volume is high and they lead to natriuresis. Uresis means excretion, natri means salt. If it is water, then it is diuresis. If it is salt, then it is natriuresis. So they lead to natriuresis, that is sodium excretion, and they oppose RAS. So basically, the only thing you need to remember is that kidney responds to EABV and not total body fluid. So now a little bit about water regulation and hyponatremia. Like we discussed earlier, that serum sodium is a marker of water balance. So the serum sodium is not reflecting the actual sodium inside your blood, but the ratio of sodium to water. So this signifies that if there is a issue with serum sodium, then it is not representing a effective decrease or increase in the sodium, but a primarily water problem. In case the serum sodium is low, it is because of excess water. In case the serum sodium is high, this is because of water deficit, as it is a ratio. So there are different controls. One is ADH control. ADH is released when the osmoreceptors in your hypothalamus sense increased osmolality, and they cause secretion of ADH. For example, other than this, it can also be volume control. Like ADH can either be released due to increased osmolarity or can be also increased due to decreased EABV, that is effective arterial blood volume. Both these will lead to increased ADH. ADH will prevent diuresis, that is, that will prevent water being excreted into the urine. The urine that will be excreted if there is ADH will be very concentrated and not dilute. You have to remember that volume overrides osmolality. This point we will also discuss again. So basically, the thing is that ADH can, like we discussed, can be released through both osmotic derangement or volume derangement. However, the more sensitive one is osmotic. So even if there is a small change in the osmolarity, ADH will be released. Volume is not very sensitive. That, for example, it will require a change in at least 10% for the ADH to be released. However, the quantity of ADH released is far much more when there is a derangement in volume than in osmolarity. This is what this sentence is trying to tell, that volume overrides osmolarity. So again, understanding that line, that when volume is low, the body ignores osmolality and prioritizes perfusion. So if the body senses, if the receptor sense that the volume is low, the EABV is low, they will cause massive ADH release. Even if already the plasma is hyposmolar, that is, it is dilute. Even if the osmolality is already low, despite that, due to low volume, ADH will be released. So the receptors will prioritize control of volume over control of osmolarity. and body will retain water. And it is logical that you can tolerate a slight shift in your osmolality, but you cannot tolerate decreased DABV because it is responsible for your organ perfusion and functioning of different organ systems. Clinical examples of the same where volume is prioritized over osmolality. One is heart failure, in which the due to increased total body fluid, the serum sodium can be low and the osmolality can be low, but the EABV will be low and still ADH will be released, leading to further dilutional hyponatremia. Similar thing will happen in cirrhosis due to splanchnic pooling of blood. So now discussing a bit about hyponatremia. Hyponatremia is a thing that you get to know through lab. The lab report will tell you. Then you have to clinically define it into three categories. One is hypovolemic, euvolemic, and hypervolemic. The different indicators that you can use to decide it is decide the volume status is either you can check for any edema, you can check for any crepitations in the lung, you can check the capillary refill time, you can check the tongue and mucosa are wet or not, if the eyes are sunken or not, and they will give you idea whether the patient is hypovolemic, euvolemic, or hypervolemic. The examples of hypovolemic hyponatremia is when the loss of sodium is more than the loss of water, that is in seen in increased ADH state. Then euvolemic hyponatremia is seen when there is inappropriate ADH secretion, that is SIADH. And hypervolemic hyponatremia is seen in CHF and cirrhosis, where there is perceived low volume due to low EABV leading to high release of ADH. So basically, all forms of hyponatremia involve ADH. Again, try to remember that hypernatremia is not an issue with the sodium, but it is a disorder of water, and this sodium is being corrected through ADH. So the summary of all that we discuss is that serum sodium is a primarily reflection of water balance and not sodium. This water balance is regulated by ADH, and it release is controlled both by osmolality and volume. The volume depletion overrides osmotic control, leading to ADH release even when sodium is already low. This explains why there is hyponatremia in different conditions, because the body is trying to maintain the circulation despite even though that is leading to hyponatremia. Now we will see a little bit about potassium handling. Potassium is basically handled at the DCT. This is the principal cell in the DCT where aldosterone acts. So this is the luminal side, the tubular fluid side. This is the basolateral side. So aldosterone, again, like we discussed earlier, comes through that first aldosterone secretion is triggered either by increased potassium in the blood or it's by a RAS activation when there is low EABV. So this aldosterone when through blood will come through the peritubular capillaries, diffuse out and enter inside the cell and lead to its action. The different actions it lead to is increased ENaC channel in the luminal side that leads to sodium absorption, increased ROM-K channels in the luminal side leading to potassium excretion, and then this gradient is balanced by sodium potassium ATPase at the basolateral side. So basically potassium is freely filtered. It is reabsorbed in PCT and loop. However, there is no regulation of levels. The regulation is done at the DCT. And it is the distal secretion that determines the potassium balance, the principal cells of the collecting duct. On the basolateral side is the sodium potassium ATPase, and on the apical side are the ROM-K channels. And if you can see that it is the sodium reabsorption that is driving potassium secretion to maintain out the charge and to maintain the balance. So the major regulator of potassium is aldosterone, which increases ENaC, increasing sodium reabsorption and increases potassium secretion. Then the second is distal sodium delivery. More sodium is delivered to the distal part, more it has to be absorbed and more the potassium will have to be excreted as a sacrifice. Then the flow. Again, it is similar to like more salt delivery because the flow in itself is delivering the solutes. Na? So if the flow rate is high, that will lead to washing away of potassium. So you need to remember that potassium excretion depends on distal secretion and again sodium absorption. The more sodium that is reabsorbed, the more potassium is secreted. Again, it is just a summary that potassium excretion depends on aldosterone, sodium delivery, and flow. So you have to clinically integrate this physiology. Is that when do you will you see hyperkalemia? You will see hyperkalemia in the state where aldosterone is low. Aldosterone is low. Either it can be due to a disease where the body is not able to synthesize aldosterone, that is a Addison's disease, or it can be due to blockade of RAS pathway, that is ACE inhibitors and ARBs. Then it can be due to decreased sodium delivery, that is AKI. In AKI, the sodium delivery at the distal part will be low, and so no more potassium will be sacrificed, or there will be no normal secretion of potassium because there is no sodium incoming, and again low flow in conditions of oliguria. Then hypokalemia will be seen when you're giving diuretics because they increase the sodium distally, and to absorb that sodium, potassium will be sacrificed. Then if there is some tumor or some other cause of increased aldosterone in the body and high flow states, there are certain drugs that can lead to hyperkalemia. One is spironolactone. It is also known as potassium sparing diuretic. It interferes with the action of aldosterone. That is why it leads to hyperkalemia. And then, like we discussed, diuretics. Furosemide is an example of loop diuretic that will increase the distal sodium delivery, leading to hypokalemia. Then we will see a little bit about the calcium phosphate regulation and CKD-MBD, where CKD-MBD is chronic kidney disease, mineral bond, CKD associated mineral bond density disease. So basically, you have to remember that kidney is also an endocrine organ. And vitamin D, one step of activation of vitamin D occurs in kidney. Basically, there are two hydroxylations that are required for vitamin D to be made into an active form. One is done at the liver, and the second one is done at the kidney. What this vitamin D does after activation is that it increases absorption of calcium and phosphorus from the gut. Then the second regulator is PTH. There are receptors that sense the calcium level in the blood, and in response to this, PTH is secreted. PTH increases calcium in the blood, decreases phosphate, and it also increases bone resorption in an attempt to increase calcium in the blood. Then the third regulator is FGF23. FGF23 is a phosphoturic molecule. Basically, it causes excretion of phosphate in the urine. And but along with it, it is also an antagonist to vitamin D, as vitamin D along with calcium also increases absorption of phosphate. So normal physiology, the kidney excretes the phosphate, activates the vitamin D, and there is a balance maintained of calcium and phosphorus. In CKD, what happens is that there is decreased GFR, which will lead to decreased excretion of phosphate, and this phosphate will start to get accumulated in the blood. Now, like I told you, FGF23 is a phosphoturic molecule, and so in response to high phosphate in the blood, high amounts of FGF23 will be released. They will antagonize vitamin D. This antagonization of vitamin D will lead to decreased calcium absorption, decreasing the calcium levels inside the body, and that will be sensed by PTH, and that will lead to increased PTH. This PTH is increased not because of some primary illness in the parathyroid hormone, but due to some other issue. It will be called secondary hyperparathyroidism. So primary hyperparathyroidism is in which there is some issue in the parathyroid gland itself. Secondary is in CKD, and but still, if you like maintain the calcium levels and you maintain the vitamin D levels, this can be controlled. But if it runs for a very long time, this can become autonomous. That is known as tertiary hyperparathyroidism. So basically, the final outcome of all this is the bone disease and vascular calcification. So just remember, CKD will lead to decreased phosphate excretion, that will lead to increased PTH, and that will lead to bone disease. So, like I told you, secondary hyperparathyroidism is seen in CKD. This high PTH will lead to bone damage, that is renal osteodystrophy. It will also lead to vascular calcification due to deranged. Basically, calcification is also determined by the product of calcium and phosphate. As in all this disease, the product is being deranged, so it can lead to vascular calcification. So, the treatment is that you decrease the level of phosphate, maintain vitamin D and calcium in the body. Now FGF23 is also used as a marker. It is an early marker of CKD. It will be increased even before PTH. If you are suspecting someone to have CKD, you can check their FGF23 levels. So now we will just discuss few more concepts and that will end this lecture. So one thing is glomerulotubular balance, GTB. So basically you have to remember that the proximal tubule reabsorbs a constant fraction. The friction that is being absorbed is constant, even if the filtered amount of fluid through the glomerulus decrease or increase, the PCT will absorb a certain fixed friction out of that filtered part, and that is 65%. So basically, this is how this GTB, the glomerular tubular balance, is maintaining this. So you have to remember this one equation. Basically, this is we have discussed it earlier. PUF is the ultrafiltrate. Ultrafiltrate is basically that what is being formed inside the tubule after passing through the glomerulus. So it is determined by PGC, the hydrostatic pressure inside the glomerulus, minus the hydrostatic pressure inside the Bowman space, minus pi GC, that is the oncotic pressure inside the glomerulus. And the net number that comes after all this determines the ultrafiltrate. We will discuss this diagram in the next slides. So basically, glomerulus is responsible for filtration. The blood enters via efferent arteriole, and in the once it is entering through the efferent arteriole inside the glomerular capillaries, the PGC, that is the hydrostatic pressure, is 50, and pi GC, the oncotic pressure, is 25. And in Bowman space, as there are in normal physiological condition, no protein leaks through it, so it won't have any protein. So the pi BS is 0, and the hydrostatic pressure is 10. So the net effect is 50 minus 25 minus 10. As it comes as positive, the fluid enters into Bowman space. Now, as this is moving through the glomerular capillaries, the protein amount will keep increasing. The concentration of protein will increase. However, the amount of water as it is being filtered will keep decreasing. So the hydrostatic pressure will decrease. So as you reach the efferent arteriole, the pi GC, the oncotic pressure, has increased to 35 and the PGC decreases to 47. But still, it is a positive thing. Like PGC minus pi GC minus PBS is still positive. So the ultrafiltrate will continue to form. Now in peritubular capillaries, you see in the initial part, like we discussed, due to increased protein density and decreased fluid, the oncotic pressure will be high and the hydrostatic pressure will be low, that is 20. So it will have a negative, like it will have a suctioning effect. This high oncotic pressure will pull fluid from it, aiding in reabsorption. But as it continues to absorb more and more water, as it reaches the far end, you will see that the hydrostatic pressure has now decreased to 15 and the oncotic pressure has now decreased to 25. But still, the pi PC is more than PPC, so it will still continue to absorb water. Uh, because it is always higher than the hydrostatic pressure, that is PS of the interstitial space, and the oncotic pressure pi S, that is 6. So the net pressure that is pushing fluids is 2 here because of high hydrostatic pressure, and because of high oncotic pressure this thing is also pulling. So basically this and this both are aiding in reabsorption of fluid. So the fluids moves back into capillaries. So what is the switch happening? At glomerulus, the dominant force is the high hydrostatic pressure. However, in the peritubular capillary, it is the high oncotic pressure. Because here we need fluid to filter out and here we need the fluid to get reabsorbed. So now the clinical condition is that this glomerulus and that peritubular capillaries are connected through efferent arteriole. If anything constricts the efferent arteriole, it will increase both GFR and both peritubular reabsorption. And this synergistic increase is what is the glomerular-tubular balance. That how the constant fraction that is being reabsorbed through the PCT remains same. As if the GFR is increased, so is the peritubular reabsorption. So this graph is basically showing the same thing that we have discussed. The red line is the oncotic pressure of glomerulus and the green line is the hydrostatic pressure of glomerulus, and this yellow part is the net pressure that is responsible for formation of ultrafiltrate, for the filtration out of fluid. And you see that even though the gap at the very end, this is efferent arterial, this is efferent arterial, decreases, it is still positive. So the filtrate continues to form even at the very end. So what can happen is that in a condition where the renal plasma flow decreases, the gap in between them might decrease, decreasing the filtrate and leading to decreased GFR, which we call as acute kidney injury. in case of a decrease in the plasma flow like dehydration or shock. Now this diagram is about the peritubular capillaries. The red line is the oncotic pressure of the peritubular capillaries and the green line is the hydrostatic pressure of the capillary along with interstitial oncotic pressure. So basically these are the two values, the oncotic pressure inside the capillary and the hydrostatic pressure inside the interstitium that is the responsible for reabsorption, and these are the opposing force. In the initial part the gap is high which decreases at the end but still remains positive, and that is why at the very end also the peritubular capillaries maintains to reabsorb the stuff out. So again, the observation of that graph is in the beginning, the net absorption is 17 millimeters of mercury, which is strong. At the end, it decreases to 12 millimeter. So the reabsorption occurs along the entire peritubular capillaries. Uh, so basically, all this was to explain to you how, despite increase in GFR, the PCT reabsorption will also increase, and the constant fraction 65% will remain the same. For example, if there are 100 units that are being filtered through glomerulus, PCT will reabsorb 65, that is 65%. If it increases to 150, PCT will reabsorb 97. So the fraction will be maintained. In summary, why all this was happening, it is because of the peritubular Starling forces where the oncotic pressure is higher, thus pulling out fluid, reduced hydrostatic pressure inside the peritubules, which is the opposing force, and flow dependent reabsorption. More tubular flow increases more sodium, which increases reabsorption. So basically, filtration and reabsorption are coupled with peritubular capillary dynamic. Why do we need this GTB, glomerulotubular balance? It is because if in case there is a sudden increase in GFR and there is no GTB, there will be massive fluid loss. But if there is a GTB, that will prevent any loss of ions or water. That is why the nature has made this system. Thus, it will help kidney to maintain its basic function of maintaining homeostasis. Now we will see something about renal oxygenation and medullary hypoxia. So basically, there are two types of nephron. One is cortical nephron, in which the loop doesn't go very deep down in the medulla and it ends in the upper part of medulla. And then there is juxtamedullary nephron, in which the loop goes very deep down inside the medulla. Now the thing is that kidney receives 20 to 25% of cardiac output. Basically, if the cardiac output is 5 liter, kidney will receive 1 liter of blood. But despite that, the kidney works in a hypoxic uh, environment. The reason is, you see, the PO2 at the cortex is 70 millimeter of mercury and it reduces down to 10 millimeter of mercury. And this is the part, the juxtamedullary nephron and the loop of that juxtamedullary nephron is a highly metabolic part. So it requires high amount of oxygen. That is the issue, that even a minor change in oxygen levels can lead to damage to kidney because they require high amount of oxygen and already are working on a compromised value of oxygen. So basically, why this sudden decrease in oxygen? This is because the nature has made the counter current system. The loop of Henle is a counter current multiplier, and this peritubular capillaries is counter current exchanger to maintain the gradient. But it is so intricate and so close that oxygen directly diffuses out from the descending limb of the peritubular capillaries to the ascending limb of peritubular capillaries, forming a diffusing shunt. So rather than the oxygen normally traveling from the descending limb to the very deep loop and then coming up, directly goes from here and there, thus leading to a decreased amount of oxygen available for the lower parts of the loop, which makes them vulnerable to hypoxic damage. So consequence of this system is that it reduces oxygen delivery to medulla and making a relatively hypoxic environment that can lead to damage. So like why is the medulla hypoxic? Many reasons. One, the uneven blood flow. Like even without this diffusive shunting, the amount of blood in the cortex is 90%. However, medulla only receives 10% of it. Then the oxygen shunting, which we discussed, that how oxygen directly shunts from the descending limb to the ascending limb without going very deep down. And the third is high metabolic demand. because the thick ascending limb has many active channels that require energy, and energy requires oxygen. So you need to remember that renal oxygen is determined more by tubular workload than by blood flow. So some clinical examples. One is ATN. ATN is acute tubular necrosis, and the most common area where ATN is found in hypoxic condition is in the outer medulla. That is the thick ascending limb, because that is the most vulnerable area. Then is contrast induced nephropathy, as the medulla is already working in a hypoxic environment, and contrast can lead to vasoconstriction, further decreasing the oxygen, leading to damage. Then the third is loop diuretics. The loop diuretics will block many channels in the loop of Henle, and that blockage of that channels will prevent the energy that was being used to operate that channel. Thus, sometimes loop diuretic can improve medullary oxygenation by decreasing the metabolic demand. Then in sepsis, there is microcirculatory dysfunction, and that leads to oxygen delivery mismatch. Even though the total global flow to the kidney might be same, but due to microcirculatory dysfunction, the medulla will be further hypoxic. So now we will discuss another important concept of urea handling. So for urea handling, we will see step by step how urea is handled by the kidney. So the first thing to know is that urea is freely filtered from the glomerulus. So it will enter the nephron, the tubular lumen of the nephron through the glomerulus, as it is freely filtered. In the PCT, almost 50% of the urea is absorbed, but there is no regulation of the urea levels here. Now in the loop of Henle, when it goes, the thin ascending limb, the inner medulla, is permeable to urea. So some amount of urea can like leave out the tubular fluid and enter inside the interstitium and accumulate in the medulla. Now the collecting duct is the main site where the regulation of urea is done. So basically, if ADH is present, the inner medullary collecting duct becomes permeable to urea, and large amount of urea leaves the tubular lumen and enter inside the medulla. And inside the medulla, it will increase the medullary osmolarity, thus helping in the counter current exchange and multiplier gradient. Now there is another thing, that this urea is also recycled. From the collecting duct, it enters into the medulla, the interstitium of medulla, if ADH is present, and from the medulla, it again diffuses into the loop of Henle, and then again returns to collecting duct. This traps the urea in medulla. So, and this again, this whole recycling helps in amplifying the osmotic gradient. So this diagram is again explaining the same, how urea is freely filtered from the glomerulus, enters inside the tubular fluid. In PC2, almost 50% is absorbed. In the thin ascending limb of Henle, some of it can diffuse out into the medulla. Then as it goes into the collecting duct, if ADH is present, it will diffuse out and enter inside the medulla, increasing the gradient and helping in counter current exchange and multiplier gradient, the osmotic gradient required for water absorption, and then can again diffuse inside the loop and again come into collecting duct. And this whole is called urea recycling. So what is the role of urea? First, it helps in urinary concentration, as it is helping in increasing the medullary osmolarity and the gradient formation. Then it is ADH dependent. ADH need to be present for urea to diffuse out of the collecting duct and take part in urea recycling. If someone is low protein diet or liver disease, that can decrease urea, affecting the medullary osmolarity, thus impairing the urinary concentration power. It can also be used as a therapy as an osmotic agent. Now we will see a bit more about the TGF, that is tubulo-glomerular feedback. So basically, if you see, this is the efferent arteriole, this is the capillary network in the glomerulus, this is the Bowman space, and the distal part, the DCT, passes in a very close proximity to this efferent arteriole. And here is the macula densa, the specialized cells that can sense NaCl. Then this is the mesangium, and then this afferent arteriole has certain granular cells that can increase renin. So this whole helps in adjustment of this arteriole to stabilize the GFR. So basically, how step by step it acts. First, the sensor is in macula densa. This is the lumen of DCT. These are specialized macula densa cells. They have this NKCC2 receptor, and it senses the solute load. In case the solute load is high, let's say that the NaCl coming at this point is high, it will lead to release of adenosine by a breakdown from ATP. Now this adenosine will go and act on A1 receptors on the efferent arteriole. That will lead to constriction of efferent arteriole, decreasing GFR. Now let's say the opposite happens and the NaCl delivery at the distal lumen is low. Then that will lead to decreased breakdown of ATP, decreasing the adenosine, thus it won't be able to vasoconstrict the efferent arteriole. At the same time, it will increase nitrous oxide and prostaglandins that will dilate this efferent arteriole and will also stimulate renin release. That will lead to activation of RAS, formation of angiotensin 2, that will lead to constriction of efferent arteriole. So dilatation of efferent, constriction of efferent, thus increasing the GFR. So you need to remember that distal NaCl delivery is a feedback to control proximal filtration, and the tubuloglomerular feedback couples tubular workload to glomerular filtration. Why it matters? Because it prevents over or under filtration, matches the GFR to the absorptive capacity of the kidney, and stabilizes distal delivery. A bit about diabetic hyperfiltration. So basically, what happens in diabetes, as I said, that there will be increased glucose is freely filtered from the glomerulus to the Bowman space. If in diabetes the blood level of glucose is at a high range, so the amount of glucose reaching the PCT will also be high. So that excess glucose will be reabsorbed, but at the cost of sodium, because the channel through which glucose is absorbed is SGLT2, sodium dependent secondary active absorption. So more amount of sodium will also be extracted than the normal physiological amount from the tubular fluid in the PCT. But it will lead to is that it will decrease the solute reaching to macula densa, and macula densa will erroneously interpret it as low flow. That's the GFR is low, and thus NaCl is low. However, that is not the case. So there will be pathological activation of the tubuloglomerular feedback, leading to increased renin. That will activate the RAS, decreasing adenosine, increasing nitrous oxide, leading to efferent dilatation. So initially in diabetes there is hyperfiltration, it will increase GFR, but the issue with this hyperfiltration is that it will increase the local pressure inside the glomerulus, and like hypertension damages the vessels, this locally increased intraglomerular pressure will also damage the glomerulus, thus leading to the advanced stages of diabetes as it progresses. So chronic hyperfiltration leads to glomerular injury and proteinuria. So there is this SGLT2 drugs, which we have also talked about earlier. Basically, what how do also the first thing they do help is by they will increase the amount of glucose going into the urine, thus lowering down the glucose level. Second, they are renoprotective. How are they renoprotective? Is as they block this SGLT2, the excess sodium that was being absorbed will not be absorbed and will reach the macula densa, and macula densa won't activate the RAS, thus preventing the first stage itself and preventing further kidney damage. So this diagram is again trying to explain the same, that how if there is normal GFR and normal sodium level reaching to macula densa, the TGF excess is normal. If there is increased glucose, increased sodium absorption, decreased sodium at macula densa, and that will lead to pathological activation of TGF. Once you give SGLT2 inhibitor, they will prevent this excess sodium reabsorption, and again it will restabilize the TGF. Other clinical uses are when you give NSAIDs, so they will block prostaglandins that will impair efferent dilatation, decreasing GFR, especially if already patient has a low perfusion state, patient is in shock or dehydration or has congestive heart failure, like the effective arterial blood volume is less. This we have also discussed before. Similarly, ACE inhibitors decrease the efferent tone and can can impair GFR, but why they are also renoprotective. When you give them along with SGLT2, they will decrease the efferent tone. Thus, they will also effectively decrease the intraglomerular pressure, thus hampering the kidney damage being caused by diabetes. Now we will see a bit about the concept of filtration fraction. Basically, filtration fraction is the proportion of renal plasma flow RPF that gets filtered. So basically, filtered fraction is GFR by RPF. How much of the renal plasma that is being reaching to the kidney is being filtered. That is filtration fraction. Normally it is 20%. That is, if 1 liter of blood is reaching the kidney, then 200 ml will be filtered and 80% will go into the efferent arteriole. Why do we need to study about filtration fraction is because it reflects the intraglomerular hemodynamics. Basically, it isn't about the flow but about the pressure dynamics, because this FF determines the peritubular Starling forces. If the filtration friction is more, that means more amount of fluid is being filtered from the glomerulus into the tubule. Then in the efferent arteriole, there will be less amount of fluid, more amount of protein. So that will increase the protein concentration in the efferent blood. That will lead to increased oncotic pressure, and that will increase the PCT reabsorption due to increased gradient. So FF tells you how hard the glomerulus is working relative to the blood flow. There is another way you can calculate FF is by inulin clearance divided by PEH clearance. Why? Because inulin is the ideal marker of GFR and PEH gives you renal plasma flow. So in if we say that the filtration fraction is increased, so like I said, filtration fraction is GFR divided by RPF. That means either GFR is increased or RPF is reduced. It is seen in condition like RAS activation, because what RAS does it will cause constriction of efferent arteriole, thus increasing the GFR. But it will also constrict the major artery supplying the kidney. So in total, it does increase GFR by constricting the efferent arteriole, but grossly it reduces the blood supply reaching to the kidney. Therefore, the FF increases. Apart from this, it is also seen in shock and hypovolemia, because already there is less blood that can reach to the, like in the whole body, the amount of blood that can reach is less. So obviously kidney will also have less blood. However, this will be sensed by the kidney receptor and they will activate the RAS system that will increase the GFR by again constricting the efferent arteriole. So in RAS activation through some disease process or shock or hypovolemia where it is physiologically active, the filtration fraction increases. Filtration fraction decrease either, this basically means that the GFR is reduced relatively to RPF. When do you see it? You see it is when you give ACE inhibitor, because ACE inhibitors will hamper the angiotensin 2 mediated efferent arterial constriction, leading to dilatation, which will decrease the GFR, thus decreasing the filtration fraction. Or if you cause dilatation of efferent arteriole, that will increase RPF and will have less relative filtration. So again, clinical integration, like I said, that if RAS is activated either through pathological process like CHF cirrhosis or through physiological process in which it is required, just dehydration, that will lead to increased filtration fraction, that will lead to increased oncotic pressure in the peritubular capillaries, which will increase proximal sodium reabsorption, thus maintaining the constant fraction the PCT needs to absorb. Adjusting the absorption at the level of PCT is done by this filtration fraction. Then as you give ACE inhibitors, the filtration friction reduces due to hampering of efferent arterial constriction. Thus can lead to rise in creatinine. In diabetic nephropathy, like we saw, that initially it leads to increase in intraglomerular pressure. So can initially increase the filtration fraction. However, in long term, this will decrease the FFs. Then there is this one important concept of pressure natriuresis. Basically, it is a physiological thing. Any increase in your arterial pressure can directly increase the sodium and water, as water follows sodium excretion, independent of any endocrinal hormone. So as BP increases, sodium excretion also increases. How does this happen? Basically, first thing is very simple, because there is increased perfusion pressure of at the kidney. So that will lead to more filtration, more tubular flow. So that will increase the amount of sodium and water the kidney can excrete. The second thing is by reducing the tubular reabsorption at the level of PCT, because this increased sodium, like basically increased hypertension in itself, changes the peritubular capillary dynamics that we will see in the incoming slide. And third is as it increases the blood flow in the peritubular capillaries. And like we discussed, that the slow flow is also essential component of the counter current exchange. So if the flow is not slow, it will destroy the gradient, thus decreasing the reabsorption. So the second point that I was talking about, that how come reabsorption decrease with increased BP despite having a glomerulotubular check in C2, which we discussed earlier. Because pressure natriuresis is not about GFR, it is about the peritubular capillary dynamics. As the arterial pressure increase, the renal perfusion increase, that will decrease the filtration fraction. So less plasma will be filtered relative to the flow. So in the peritubular capillaries now the amount of fluid is relatively more. Thus the oncotic pressure that the proteins can exert is less, and the hydrostatic pressure that is physiologically present will be increased. So basically the reabsorption from tubule is based on two things. First is the oncotic pressure that will pull the fluid, and second is the hydrostatic pressure that is opposing this process and usually low. But now as the filtration fraction has decreased, the oncotic pressure will be low and the hydrostatic pressure will be high. This will affect the absorption, will decrease the absorption. So GTB is still present, but it will only operate within the tubule related to the GFR, but not at the peritubular network. So GTB preserves fractional reabsorption, but increased arterial pressure reduces peritubular reabsorption. That is net. There will be natriuresis. So this is why when you give ACE inhibitors, again, like we discussed earlier, that how ACE inhibitors decrease the filtration fraction, decreasing the oncotic pressure, and then leading to natriuresis, thus helping in reducing the BP. This basically this theory is Guyton's theory. So if you see on this graph, the x-axis is the blood pressure, and the sorry, the x-axis is the blood pressure, and the y-axis is the natriuresis, the amount of sodium excreted. This is a normal human being. This is someone who is resistant to the amount of salt they ingest. That is, their BP doesn't get affected substantially by the amount of salt intake, and this is a salt sensitive subject. That is a person who, based on their salt content, have their BP substantially affected. So basically, normal purple curve, you can see it as a moderate slope. That means any small change in BP leads to significant increase in sodium excretion. Now, salt resistant is the blue curve. It has far more steeper. That is, even when high salt intake, kidney excretes sodium effectively. You see, the so arterial pressure has increased, but the slope is steep. Then salt sensitive. These are the people who need to have a dietary control on salt. They see the first thing to the graph has been shifted to right. That is the amount of BP required to excrete this amount of sodium has progressively increased. Second, this graph is no more steep but very flat. So this is seen in patients with CKD, elderly, and some genetic predisposition in which, as you increase the salt intake, the amount of blood pressure required to excrete that amount of salt increases substantially. So this is better explained by this curve, which is known as Guyton's curve. Now this point A is the point of normal equilibrium. Basically, this is the point where your intake of sodium is equal to your output of sodium, and it is usually seen at the BP of 100 millimeter of mercury. So body is in a steady state. Now what will happen as your salt intake increases? So basically for that, first you see what one is this graph representing. On x-axis is the mean arterial pressure, y-axis is the intake and output of salt. And the red curve is the renal output of sodium plus water, basically the pressure natriuresis curve. And this horizontal line is the dietary intake of salt. So basically, suppose you say that you suddenly increase your salt intake. So if the intake will be more than output, we are past this equilibrium point where intake was equal to output. Before this, the intake will be less than output. Up beyond this, the intake is more than output. So due to this, the body will start retain fluid. Like I said, that so water follows sodium. So if the intake of sodium is more than how much your kidney can excrete, the body will start to retain fluid. That will increase your blood volume. That will increase your cardiac output. That will increase your BP. This increased BP is what is represented by the shift of point A to point B. And this is what happens in a chronically hypertensive patient, that the equilibrium point where the intake is equal to output shifts to a higher blood pressure range. So, in a normal subject, the equilibrium is at 100, but in a chronically hypertensive patient, the equilibrium point shifts at a higher BP, around 150. And it is at this blood pressure where the body is in a steady state. However, this blood pressure will continue to cause pathological damage to your body. So even though the balance is restored by compensatory mechanisms in the body, the patient becomes hypertensive. That is why people have high blood pressure, because their kidney is trying to maintain the homeostasis. So this is the key concept, is that long-term arterial pressure is the pressure basically which is required by the kidney to excrete the daily amount of salt you are consuming. That is why it is necessary to have a limit on your salt intake. Now this graph is representing why we use drugs like angiotensin 2 blockers, which can be ACE inhibitors or ARBs. So basically this green curve is representing the high angiotensin state. This black line is normal and this red line is angiotensin blocked state. The x-axis is your blood pressure, the y-axis is your sodium intake is equal to output equilibrium state. So in green dash state, that is if you have high angiotensin 2, the curve is shifted to right. That is for the same amount of sodium to be excreted. To achieve the balanced state, you need a higher blood pressure. Normal, like we saw, that the normal equilibrium point is at 100 millimeter of mercury. And once you block this angiotensin 2, this curve shifts to further right. And now the blood pressure required to maintain that equilibrium point is far low. That is why these drugs are used. So again, if in hypertension the pressure natriuresis curve shifts to right, meaning higher BP is required to excrete the same amount of sodium to maintain the ideal state, to maintain the sodium levels. So kidney resist sodium excretion if the BP is not increased. Example is CKD, RAS overactivity due to any other cause or salt sensitivity. Then what do diuretics do? Diuretic increase the sodium excretion by blocking sodium reabsorption. So now the kidney load to it excrete sodium is decreased. So now it can operate on a lower blood pressure. So the curve will shift to left and the BP will be reduced. And the RAS blockers we just saw that how inhibiting angiotensin 2 shifts the curve to the left. So summary of this is the very important thing, that pressure natriuresis is phenomena by which increase in arterial pressure leads to increased sodium and water excretion by the kidneys, independent of any hormonal influences. This is very important. And this mechanism is central to long-term BP regulation, as arterial blood pressure is a secondary thing. That it is not that the BP is increased because of high salt intake. It is the high salt intake that is causing a pressure on the kidney, and kidney has to work on a higher blood pressure level to optimize the filtration fraction in a way that you have a homeostatic state. Now a bit about potassium. Basically what happens is that the potassium levels are also correlated with your acid and base status inside your blood. So it happens through two mechanisms. One is immediate filler effect and second is delayed renal effect. In immediate filler effect, in acidosis, H plus will enter the cell because like H plus is more in the blood. So this H plus will enter inside the cell. But to maintain the electrical neutrality of the cell will cause the potassium to move out. Thus, if there is acidosis, there is will be hyperkalemia in this patient. A tendency to develop hyperkalemia. Now, same thing in alkalosis, if the hydrogen ions are low in the blood, then the cell will lose hydrogen from inside it, and this to maintain the electron neutrality will take potassium. So, potassium will move into the cell, leading to hypokalemia. Now, delayed effects. Basically, this is a principal cell. If you see, in principal cells, there is this ENaC channel. It is not in this diagram, sorry. So we saw earlier, na, there are principal cells in the DCT on which there are ENaC channels which are stimulated by aldosterone. They will cause reabsorption of sodium, and this aldosterone will also stimulate ROMK channels that will cause secretion of potassium to maintain the electroneutrality. So this is the delayed effect. And then there is these alpha cells. We saw that they work when you have to lose acid. So basically, this is the alpha cell. It has this H plus ATPase and H plus K plus ATPase. So in state of acidosis, there will be increased H plus in the body. So that H plus will also be leading to secondarily increased H plus inside the cell. Now this cell will lose this H plus, but in return will gain potassium. So this will further increase the tendency of a patient with acidosis to have hyperkalemia. And the reverse happens in alkalosis. That to prevent any H plus secretion, this channel will be hampered. So there will be no more potassium reabsorption, thus increasing the tendency to develop hypokalemia. So if you have to again see the integrated physiology in acidosis, at cellular level, K plus will shift out, leading to increased potassium in the serum. At renal level, there will be increased H plus secretion, leading to compensatory potassium, decrease in the potassium secretion. Thus, can worsen hyperkalemia, and the opposite of this happens in alkalosis. So basically, you just need to remember that acidosis causes hyperkalemia, alkalosis causes hypokalemia, both via cellular shift and renal handling. But the thing is that not all acidosis will lead to same amount of hyperkalemia. If there is mineral acidosis like HCl, it will cause more profound hyperkalemia, and if it is organic acidosis like lactic acidosis, ketoacidosis, there is less K plus shift. Now I will just finish by one or two or more slides. So microanatomy again, we have discussed all this. We will just review. So again, this is the efferent arteriole, the capillary network, the efferent arteriole. This is the thick ascending limb, and this is the distal part of the nephron going in close proximity to the efferent arteriole. Now here this is magnified. This is the lumen of DCT. These are the normal cells, lumen of DCT and lumen of TAL. These are normal cells. These are specialized cells, macula densa cells, which can sense sodium. Then this is the mesangium, the supporting cells of the kidney, and then these are efferent arteriole, and efferent arteriole has granular cells that have renin. So this macula densa can cause increased release of renin and can cause local release of adenosine to increase GFR in case there is low solute delivery at the macula densa. Now this is the electron microscopy specimen of the filtration barrier. So you see this is the capillary endothelium which has fenestration so that filtration can happen. Then this is the basement membrane that is negatively charged and prevents any loss of any negatively charged protein. And then this is the podocyte. This is the primary process and these are secondary processes. This will form the foot process and they will have a space in between that is slit diaphragm. So basically, summary and function of different cells in the kidney. There are JG cells, juxtaglomerular cells present near the efferent arteriole. They secrete renin that will cause RAS activation and hypertension. Then macula densa, which sends NaCl. Any dysregulation can lead to hyperfiltration and diabetes mellitus. Podocytes, they form slit diaphragms. If any damage, can lead to nephrotic syndrome. Then basement membrane is a size and charge barrier. If affected, leads to albumin leakage. PCT cells are the main reabsorptive part of the kidney. If affected, leads to Fanconi syndrome. Then TAL, which has NKCC2. If it is affected, it will lead to diuresis because sodium will be lost and water will follow it. This is also blocked through drugs like loop diuretics. That will decrease the gradient, decreasing the reabsorptive capacity and causing more urine to be loosed inside the urine. Then principal cells, aldosterone acts here, causes sodium reabsorption, potassium secretion. This ENaC can be inhibited by drugs like spironolactone and thus they can cause hyperkalemia. Then alpha intercalated cells which are responsible for loss of acid and they will uh, मतलब any damage at alpha intercalated cell leads to distal RTA or type 1 RTA. Then vasa recta countercurrent exchange. It preserves medullary gradient. If the flow is too fast, they can cause washout of the gradient leading to dilute urine. So now just a final recap of all that we have discussed. Core equation you need to remember GFR is a directly proportional to net filtration pressure. Excretion is the sum total of filtration minus reabsorption plus secretion. Formula of clearance and formula of filtration friction and the normal value. Then how kidney is regulating what? Kidney regulates sodium that regulates your volume or EABV. Kidney regulates water through ADH, kidney regulates potassium at the distal part through secretion, and kidney regulates potassium at the same. Always remember, kidney will prioritize circulation over chemistry. Role of segments: glomerulus is the filtration part, PCT causes bulk reabsorption, loop forms gradient, DCAT causes fine sodium, potassium, and hydrogen control, and collecting duct is the site where ADH acts. Hemodynamics: efferent constriction will lead to decrease in GFR, efferent constriction will lead to increase in GFR initially, later it can lead to increased oncotic pressure inside the capillaries, which can decrease GFR. RAS causes efferent constriction, so leads to increased filtration fraction. Basically, RAS increases GFR but decreases renal plasma flow. Thus, it will increases filtration fraction. ACE inhibitors decreases filtration fraction. So, you need to remember that RAS preserves GFR but not perfusion. Then about TGF, TGF is a function of macular densa that senses the solute delivery. If there is more NaCl, adenosine is released that will cause constriction of efferent arteriole. Low NaCl, renin is activated along with dilatation of the efferent arteriole. In diabetes, there is a perceived solute paucity. However, it is not actual, so it leads to a pathological increase in GFR. Then we saw the counter current gradient, then which is formed by the loop, preserved by the vasa recta, and amplified by urea. Then sodium and volume. Basically, volume is a sodium determines your volume, and kidney senses EABV, not the total fluid inside the body. States where there is perceived states of hypovolemia due to low EABV, CHF, cirrhosis, nephrotic syndrome. Then again, serum sodium is a marker of your ratio of sodium to your water. So sodium is indirectly representing your water balance, and this is controlled by ADH. And your body tries to maintain volume over osmolality. That is why you can have hyponatremia in an attempt to maintain the volume. Then potassium is controlled by the distal nephron. It is regulated by aldosterone, distal sodium delivery, and the flow. More the sodium delivery, more will be the potassium secretion. Then acid base, the PCT is responsible for bicarbonate recycling, and collecting duct, and DCT is responsible for generation of bicarbonate and H plus secretion. In acidosis, potassium level increases in the serum. In alkalosis, it decreases in the serum. Then the calcium phosphate axis, basically if any injury to the kidney, that will decrease the GFR, increase the phosphate, that will increase FGF23, that will decrease vitamin D, this will decrease calcium, that will increase PTH. This will lead to renal osteodystrophy. Then filtration fraction, RAS and stress increase filtration fraction, ACE inhibitors decrease filtration.